we can get started if that's okay, Dr. Stevenson.
I'm ready.
And before we do, this is part 5. This is the final series to the webinar series. And so I just want to send a sincere thank you to you, Dr. Stevenson, and everyone out there across, frankly, the planet, right, that hung in there and stuck with us through all 5 series. It's been a pleasure hosting with you, Dr. Stevenson, and attending and learning with everyone there. So with that being said, I just want to make one more note. We're going to be at JDIQ in Montreal. If you want to come check out our new Ergo Loop, and make sure you go follow Dr. Stevenson on Instagram and go check out his website. And if you haven't already followed him on YouTube, go ahead and do that. Well, also where he's going to be putting out a ton of content. If you own a pair of Univet loops or buy a pair of Univet loops in the future, Dr. Stevenson is going to do something amazing for you. He's giving you 10% off his continuing education for the rest of your career. So all you got to do when you check out is email him a picture of you with your loops on, or we can see your name on the lens, and you'll get 10% off for the rest of your life. And that's very, very cool. So thank you, Dr. Stevenson. I'll hand it over to you now, okay?
Thanks so much, Devin. Appreciate it. And welcome everybody that's hung in there. I'm surprised actually we have 39 people, because it's really tough to stick with something and make it to every session. So thanks for coming. Tonight is the final session on delivery veneers, the occlusal analysis, and then the polishing. And I think we've covered a lot of things already in this series in the area of ceramics, but the thing that we haven't covered really is adhesive delivery of veneers. We really want to hear your questions and comments. We're going to get right to it. There's going to be very little true science presented. Most of this will be empirical evidence based on clinical practice, having done my first veneer case in 1986, when veneers were very, very new in dentistry, and haven't been with them all that time. That is a part of clinical evidence, isn't it? It's not all things you can read. It's also a little bit about those things that you experience. So let's get started. Okay, we haven't shown this patient yet, but she is a unfortunate but typical person that falls off of a skateboard or something like that. I think she fell off one of those little motorized scooters that were really popular for a while, and now you never see them anymore. And she face planted and fractured both centrals. She went initially to an oral surgeon who determined there were no fractures of the alveolus, and then she was then sent to an endodontist who wanted to perform root canal therapy. So we discussed this with her about what options she might have, and of course one of them was direct composite. I mean, this would be a great direct composite case, but she wanted to have something that would be the most efficient and also longest lasting. So really kind of on the border of composite or veneer. And ultimately we decided on veneers. My fee for direct composites was not going to be much different than a veneer anyway. It takes so long to do these right. So she opted for veneers. And of course, we're going to need to do some kind of wax up. This is, I hardly ever do these anymore. Mainly what I'm doing now are digital wax ups. So we do a digital wax up utilizing any one of many different softwares out there. ExoCAD is my usual go-to. And so we'll wax this up digitally and then just fabricate a cast from that. And the days of having to actually apply wax to models is very uncommon. But once these were done, we could then take this to the mouth, this wax up, and then through the use of a putty matrix, it has to be a very well made putty matrix and adapted very well to the wax up or to the printed cast. We can then take this to the mouth very quickly and have her say yes or no to where we think we're headed with this. She was ready to go. This is, just directly after it's been placed, and we haven't even wiped off any of the uncured resin on the surface, but it was an immediately accepted. And because she was somewhat excited about getting started, the preparations were initiated. And I really like using the mock-up approach because it's amazing how we will think we need to reduce something when in fact we don't, based on the final outcome. So we're essentially making a blueprint of the final prosthesis, and then we're reducing it back to the known requirements for the veneers in this particular case. And these veneers were going to be Emax because she says, I'm prone to this kind of thing. I tend to be kind of clumsy, and I want something a little stronger. So the decision was to go with Emax restorations. And also, I was concerned about the amount of remaining enamel. She'd had pretty large fractures on the lingual, and you're going to see in the final preps that there wasn't a lot of good lingual enamel left after access opening and all of the things in the fracture itself. So the Emax was chosen to create more of a wraparound veneer in this particular situation. Now these two burrs over here, the LVS4 and the LVS2, are fantastic. LVS just simply means labial veneer system. And they're great burrs. If you take a close look at the LVS4, you notice that the tip of the burr, which is the last 1.5 millimeters, is a very fine diamond grit, and it's about 30 microns. The remaining part of the burr is quite coarse. It's 125 microns. So it reduces quite rapidly where it needs to, and then it is more delicate in the fine finish line areas. And then the LVS2 is just a method for creating some depth cuts. And this one here gives 0.2 millimeters. The LVS1 gives you 0.5 millimeters. When the preparations are completed using the mock-up technique, there will be residual mock-up left over, which you need to peel off. And then I always prefer to then create a finish line on two structure. So for example, if you prepare this, ideally for veneers, pull off the mock-up, whatever remains, because it's chipping away as you're working. It's a little bit messy, but once you've got all of the mock-up removed, then you're going to want to go over the margins and make sure you create a margin so the laboratory can see exactly where the ceramic should end and the tooth begins. In other words, create a finish line for the margin of the veneer. Another key aspect that I'm grateful to my mentors over the years in showing me this is that we want to create a little bit of separation between the teeth, even if we don't extend the margin interproximally. Now, these extended quite a bit interproximally because of the fracture, but I like to create a little separation between the teeth to allow the technician to separate the dies very easily. And that really makes for a nice laboratory experience for everybody. And we want to be really careful about the amount of cord retraction we place. And you're looking at this case and going, gosh, Dr. Stevenson, I thought you use rubber dam for everything. And I know that rubber dam for adhesive dentistry is essential. In fact, I just finished an article on that for Dental Economics last month, the importance of rubber dam, but I don't like to place rubber dam while I'm preparing veneers or anterior ceramic cases. I like to use it for anything where adhesion is involved, But when it's preparation, I prefer to have the tissue present so I see exactly what's happening in a global way. Well, I want to see all the characteristics, all the scallop tissue, so things clearly helps guide my preparations a little bit. The 8850 is a fine round-ended diamond, and the tip of this burr is quite good for refining finish lines. And we're always looking for that ultimate diamond, that ultimate burr, aren't we? And this one is really, really a fantastic one. This one happens to be made by Brasser, but Meissner and Comet and other companies make very similar burrs with the same numbering system. And the key is that it has to be a fine grit. And I'm usually using the electric handpiece, and my total speed at this point is down around 10,000 RPM. I mean, it's really slow. And when we can, we like to use a microscope. And then you may want to retouch the finish lines. These finish lines are not quite finished. So you look and see some irregularities, put the microscope on, and then go after those finish lines with just a very, very small cord. And I would prefer using silk suture number 30 silk suture, or sometimes 20 if you want a little thicker, instead of this aluminum alum ginger pack braided cord, because this cord's a little thick, and I'm always very cautious about the potential for recession. The patient has a thick phenotype of tissue, is not prone to recession, so it wasn't too much of a worry here, but she tended to have oral hygiene issues, and it was difficult to keep the area free of heme and problems in the tissue in the tissues. So I did have to use a secondary cream here, this Traxident tissue astringent, which is, it's a kaolin or a clay-based product that dries up the sulcus quite nicely. And remember, I'm just barely laying the cord in here. And once again, I want to emphasize that this is an unusual case. Normally, I just use a silk suture 20 or 30. Now, you can purchase a spool of silk suture from many different medical supply houses, or even Salvin dental surgical supply, and it's really inexpensive, and you have basically a lifetime supply for very, very cheap. And then you can cut the silk suture in little segments. Don't buy a needle with the silk suture attached. That's too expensive. You're paying for the needle and all of that. You just want to buy this in a spool. It looks like something you'd see at a fishing tackle supply house or something, but it's silk. And then we cut it in little pieces, we sterilize them, and then we can use them. And then we capture the impression with the polyvinyl siloxane material. And then for provisionals, I just do a little spot etch, and the spot etch is being done at the same distance, usually away from the incisal ledge. On these, because there wasn't much incisal edge left due to the fracture, the spot etching was done right at the incisal edge. The key is you want to know where it's happening, so that when you go back to remove the provisionals, you're able to know where there may be a little bit of residual material. And then some quick provisionals are made, nothing fancy, but we made these direct. And then I laid in, I did utilize the RSVP technique, which basically you apply the bisacrylic to about half, and then you add in the flowable composite or paste composite at the gingival areas, so that you can control excess resin that goes beyond the margin. And then, of course, we're going to be doing our shade matching. The stump shade in this case was quite not a factor. She had very light stump shade, so we were able to utilize a pretty straightforward shade matching appointment. The thing you have to keep in mind is that Emax does not utilize the master pan shade system. So you can't just call this an OM1 or an OM2 or a 1M2 or something like that. You have to give the technician an ingot that they can press if it's Emax. So you have to go ahead and utilize the classical shade system, either A1 through C4, right? And then on top of that, you can talk about what kind of layering can be done. So these veneers are going to be Emax, but the lab is going to cut them back and lay in feldspathic. So I like to give the lab 2 shades, or actually 3, the stump shade, the shade of the preparation. The second thing is we like to give the shade of for the Emax, which would be the basic ingot shade, and then give a subsequent additional shade, which would be the 3D shade, because then they can cut back and add porcelains that utilize the 3D shade system. And then of course, photographs as well. And these are very average looking provisionals. This is being done in the normal practice, busy practice, lots of things happening, but she actually asked me if these were the final restorations. I said no, and she says, "Oh, why can't I just keep these?" So, it was a little bit of a low bar in terms of what the patient's demands were. It was kind of a breath of fresh air because a lot of my patients would not have that approach. They would be a little bit more picky, but she left quite happy. Now, I told her when these went out the door and the impression was being sent to the laboratory, my lab knows not to make the veneers until they get an okay from me about a week later. So what happens during that week? Well, what happens is I tell the patient to try to engage in normal conversation, realize that you probably can't bite into things like a carrot or an apple, but just chew normally, sleep, do whatever you normally do with, don't change your habits at all. Do your normal thing. But at the same time, let me know if anything chips. So if you get a chip, a fracture, something isn't quite right, I want to know about that because you're going to come in and I'm going to take a look at why that happened. And I'm going to try to figure out if that was an occlusion issue, and then maybe it was an adhesive issue, but it's usually occlusion. And if it's an occlusion issue, we don't ignore that and say, oh, don't worry. The veneers temporaries chip, but don't worry, the final restorations are strong, they won't chip. Well, wait a second, that's not necessarily true. It could be the case that the patient's occlusion and habits are telling you something. So once I get past that 1 week period, I reach out to the patient, ask them how they're doing. They tell me they're doing great. Then I tell the lab, okay, we're good to go. And that's how we roll. And I've been doing that way for 30 plus years, and it's kept me out of a lot of trouble. And there's her repose. So you're going to be in pretty good shape. Okay. So time has passed. We're now ready to deliver the restorations. So she's back in the office, and I'm going to be getting the teeth cleaned up. Like using these preppies from Whip Mix, you don't need to use this company, but you need to use some kind of a pumice that does not have any fluoride in it, which could obviously interfere with bonding. And I like these because they're cool little sterile little packages, and you don't even have to add water to them. They're already moistened to the perfect texture. And then that little cup you see over there may be a little different than you're used to seeing. This is a Young's ribbed disposable cup with a metal shank, and it fits in your latch type. It is the best cup I've ever seen. Rather than using the cheap disposable hygiene cups that we oftentimes have in our practice for our prophy appointments, I like to use these disposable single-use cups because they're so elegant. They're soft. They're shaped beautifully so they can get below the tissue level. I actually use them for all my prophies as well. And they're called Young's ribbed, not webbed, disposable gray soft prophy cups, and they're fantastic. And you can buy them in a bag of about 150 or 140 or something like that. And I've been using them and swear by them for all of our work. All of my hygiene team all use these. We never use the disposable hand pieces. I think that they're poor quality. The way they're too thick, they don't distort and get underneath the tissue. When you're doing prophies, they're kind of pretty cheaply made. These are the top of the line. I don't think there's anything better in the world than to use these for prophies and for cleaning teeth. So, you clean things up and make sure you have no residual resin. In this particular case, there is residual resin on tooth number 8, and you're gonna see the impact of what happens when you have residual resin left behind. This looks so innocent. I thought, I normally put on the rubber dam, but gosh, look at this. This will be easy. I'm going to go ahead and do this case without putting rubber dam on. And so that was my initial plan. And so here are the restorations. You can see they're more of a super veneer. They wrap around quite a bit to get past the fracture line. And I'm going to go ahead and try them in you can either use glycerin or you can use some kind of a try-in paste. If I'm using a try-in paste, I try to pick the try-in paste that is going to be the likely cement in this particular case. So oftentimes I'll use either an opaque-ish cement like a milky white, or sometimes we'll use a clear. Rarely do I have to go to a chromatic try-in paste or cement in our cases, but you need to link the veneer to the tooth. If you just try them in dry, you're not able to observe the optical properties that happen when you try them in. These are kind of cool. They're called veneer sticks, and that's actually what they're called. You can Google that and check it out. They sell these little guys that will grab the veneer and just hold it in place through friction. I think you push them on the end of this little 4-pronged rubber little end, and it just sort of pinches together and hangs onto the veneer. I don't know how it works exactly. It's just kind of maybe like one of those, you can put a decal on your car windshield and it won't come off either with no glue, right? You just put a little moisture on there and it sticks. These just work by putting them on dry, and it grabs them really well. Let's remember that when we go to try-in veneers, we're really looking at the summation of several things. It's it's the shade of the stump, the prepared tooth, plus the cement, and then also the translucency of the cement. So it's not just the cement, it's how translucent it is. And not all manufacturers have the same level of translucency of the same shade. An A1 from one company is not going to be exactly the same translucency as an A1 from another company. The shade of the ceramic, and of course also the translucency of the ceramic. So when you look at what's happening, you're looking at 5 different variables. And you have to think about what variables at the chair side can you really control. Well, the shade of the tooth, you've communicated that to the laboratory already. The shade of the porcelain is hopefully going to be based on the needs of the case and the translucency. The shade of the cement is something that you can pick chair side, but you really can't pick the translucency of the cement. That's already determined by whatever kit you happen to have. And for me, I use usually one of either 2 cements for most of my cases, because I found that the translucency is what I'm used to seeing, what I'm happy with. I wanted to show you here that this is a case that I did some years ago, and this was before cementation, but I'm trying in the same exact veneer shade on 6 different teeth. Actually, here's 5, and I'm using different try-in paste. So you can see the milky white versus the B1 versus the A2 versus the clear versus the A1. And cements do have an impact, and it's nice to be able to have an assembly of different shades, but realize that probably most of your cases could be delivered with either the milky white or the clear. Clear has a tendency to create a little bit of a gray in color, a little bit of a value decreaser. The B1, A1, and A2 also lower the value, but also increase the chroma. And then Milky Bright tends to brighten things. Most patients like the Milky Bright. They are more interested in going all the way to the brightest that they possibly can. So it's really important to pick a try and paste that matches the cement pretty consistently. And for me, and the patient chose clear in this case, for me, I like the cements that and the try and paste that come with the Choice 2 system from Bisco. I've tried a lot, and it's hard for me to endorse any particular company because I don't want to be unscientific, but I also want to let you know what I do and what I found to be work quite well for us. When you're trying in veneers, the very first thing is I just want to get the aesthetics out of the way. So I'm not even looking how they fit, quite frankly. Because I could sit there and work on how they fit and adjust contacts and get them all dialed in. And then the patient says, yikes, I don't like these. So I like to just get the aesthetics out of the way. The patient loves them. Okay, great. In fact, when I put them in, I leave the operatory. I put them in with try and paste. I leave the operatory. I don't even want the patient to feel pressured into saying yes. I don't want to have my facial expressions read by the patient. I just say, we'll try these in and give you a little bit of alone time to take a look. And that's it. I walk out. And then I'll come back about 5 minutes later. And my assistant is usually stuck around for most of that 5 minutes and talk to the patient, what do you think? And, and the assistant plays the role of advocate for the patient. Said, what do you think about this edge? Kind of being picky, and it really helps psychologically to help the patient buy into the change that they're going to be getting. Even though they've been wearing the provisionals and they already kind of know most of these things, it on that day of delivery, there's a little nervousness on both sides of the chair, right? Patient's nervous, and the dental team is a little bit nervous too, because we're not 100% sure the patient's going to be okay with things. Once that's over with, now you're ready to really get into the dental mechanics of things. Make sure things fit. And if you have to adjust the proximal contacts, you can either do it this way if you take a chance by holding the veneer this way, or you can take the die off of the cast and put the veneer on the die and brace it that way, and then you can adjust a little bit more safely. It won't take a lot of adjustments. So I like using Dialite Pink. It's not the most coarse one. It's kind of more of the fine ones. And it's sort of in the middle between the coarse and the very fine. And Dialite Pink is sort of an industry standard with my aesthetic buddies. We've always used Dialite Pink as our go-to adjuster for the veneer cases. If you had to, you could go to the most coarse, which would be the blue, but you realize that you're going to get a lot of volume removal with this particular color for feldspathic cases. If you want a different kit, you could use a different one, like this one here for Emax or this one here for zirconia. Yes, you can do the zirconia veneers as we discussed last time, but I actually believe that this is all you need, because even though this is not made for Emax, it's a little slower on Emax, but it works fantastic. And the manufacturer has come up with different grits and different chemistry in these abrasives, which makes them material specific, but they're expensive, guys. And so if this kit right here is $400, this is about $650, this is about $650, and multiple kits, it gets very costly to have too many kits at your disposal. So if you want to have all the tools, you can get them all, but I got to tell you, this feldspathic works fantastic for all of your veneers. One of the things that is quite helpful in finding areas where you have residual resin is to use some kind of a disclosing spray. This product here made by Bausch is called Artie Spray. And Artie Spray works really great to show high spots, but you have to spray it on the tooth. And you don't want to really spray it on the veneer because it can get into any micro porosities. And then to get the blue out from the veneer, the only easy way to do that is with a steamer. And if you don't have a steamer, I'd recommend that you stay away from spraying this on the veneer itself. So I like to spray this on the tooth, try in the veneer, and then it'll rub off the area on the facial of the tooth where you might have a high spot. So we made some adjustments. We don't grind on the veneer. We grind on the tooth because that's where we need to make some adjustments. Usually it can be as little as just using a scalpel blade to remove a little bit of resin excess, or sometimes it'll be a disc in the worst case scenario. Normally, I can just remove the residual resin that might be on there from the spot bonding technique you did for the provisional. I can usually remove that pretty easily with just a blade. And so you've got this veneer over here on the left, and you've got the tooth on the right, and the two of them need to come to some kind of a union. And there's a lot of things to do. I don't have the case featured to show you tonight, but I just finished a 20 veneer case, which involved premolars, upper and lower in one visit. It was, it's a long day, right? You're looking at preps that are going to take, and impressions and provisionals and photography. I would say easily 6, 7, 8 hours of hard work. The delivery is not much faster. So maybe 4 hours or so of work plus occlusion and polishing and photographs, you're looking at probably 5 or 6 hours. There's a lot to do. So when possible, I like to employ a third person in the operatory. So it's the assistant it's Millie and me. Millie is my assistant. And then I have another person come in, and that other person could be another member in the practice. It could be another assistant. I'll even enlist the help of one of my associates to come in and help me with preparing the veneers and with photography. So it's really a team approach. I think that doing this by yourself, it definitely is possible. I did it that way for most of my life, but at this stage in my life, I'm interested in, getting help on a lot of these things. And I think that that's a pretty good idea. So if you happen to have an extra assistant in the practice, helping them with getting the veneers ready, getting all the veneers properly etched with the proper time, then taking the veneers and applying the 2-bottle silane and heating them in a veneer heater so they're all ready to go. On the other side, your assistant and you're utilizing the etch. You're using chlorhexidine cavity cleanser. So you're going to help to reduce MMP activity. You're getting your adhesive ready to go. On the other side of the chair, behind you, working furiously on all of this stuff, is your second assistant, who's maybe adding the porcelain bonding resin to the inside of the veneers, and then the doctor applies the cement and then places them in the mouth. So it's just this orchestration of a team to put them all together. If you've never done a veneer case, I would highly recommend you get someone to help your assistant. So there's 3 of you. It makes a huge difference. After you get pretty experienced at these, you won't need to worry too much about that, unless the case is huge. Like in the case of 20 veneers, you're going to have a lot to do. It's a pretty labor-intensive day, and having an assistant is really helpful. At the end, of course, before light curing, we're going to use some kind of glycerin along the margins to mitigate the excess air-inhibited layer. So I think for etching, we have discussed this in previous modules. It's probably a good idea to really understand that Emax is a quicker etch than your traditional feldspathics. So when I'm working with students, for example, or other or associates that are doing veneers, I'm always, very interested in knowing what kind of material we're using, because if these are feldspathic veneers, the etch time is dramatically greater than it is for Emax. Emax etching time is significantly lower than it is for feldspathic. So it does matter. And there's so much research to support this. I think it's really important for us to follow that. A lot of different great etches out there. At this stage, I am currently using the etch by Ivoclar, but I have used all of these in the past, and I just like the Ivoclar etch at this time in my life. And we've talked about this a bit, but we need to just remind ourselves that a beautiful veneer case is not beautiful if it becomes stained within the first 4 or 5 years or something, even 10 years. I think staining is something that kind of sucks, and we'd like to try to prevent that. So let's take a look at that quickly about how do we want to prevent the stain margin problem. And one of the solutions, of course, is that, well, if I had my slide working, it would be really great. I'll tell you what, I'm going to change the color on these. Dr. Stevenson, what in the world did you do? Okay, so let's go here and we'll throw that up there. I think it'll show up now. We'll get to see the words. There we go. Margins on enamel whenever possible. Excellent fit. And we kind of blow this off sometimes, excellent fit. Oh, yeah. Yeah, excellent fit. Yeah, I got that. Yeah. Well, no, not necessarily. So many crowns and veneers get delivered that could have fit excellent, but we didn't go through the necessary steps to relieve the surface from interfering resin particles or blood or a piece of tissue or even a piece of retraction cord. I remember a doctor once that was in my study club delivered a case and had retraction cord in the sulcus to try to keep it from bleeding. And he pinched the retraction cord underneath the crown and captured it, and it was stuck underneath the crown and had to cut the crown off to remove the retraction cord. So, I mean, an experienced clinician doing that. So I think that we really need to take excellent fit seriously, and magnification is absolutely essential, obviously. And we need to have a great cement, so no cheapy cements, no stuff you can get on eBay and, outdated things, and you don't know what you're getting. You want to definitely use the best quality cement possible. Seat them fully. Just because they fit well doesn't mean you get them down all the way, right? So you need to really get them wiggled into position. And in the posterior, when I'm delivering ceramics, I really lean into the tooth and put the crown in with a lot of force, oftentimes having the patient bite down on the ceramic crown if on a wooden stick to seat them fully. And then the last thing, which we've discussed, is the bullnose etching. Really, really important. And just to remind you what that means, most etching over time just etches the inside of the restoration, and then we ending up getting some kind of debris accumulation at the margin. But when you bullnose etch, you etch beyond the corner of the veneer about 1 millimeter or so, and then when you cement this, you get a continuous seal, and we can see much nicer long-term results. So remember, for feldspathic, probably 60 to 90 seconds. For Emax, we're looking at 20 seconds of etching, and because we have a completely different substrate. So let's secure this with some kind of optra stick and utilize, I'm just using the 5% hydrofluoric acid for Emax, 20 seconds. You etch around the rim and then you etch the internals, and then you rinse like crazy for 15 seconds, and they should be good to go. And you should not see any precipitate at the finish lines. They should look nice and clean. And this is a great way to hold these. And once you've done this, then they can go into the warmer, and then you can transfer them to the veneer sticks applicator that I showed you earlier. But I like to grab them with these little sticky optra sticks, because you can rinse with pouring water on top of these and they won't fall off. And it's really great. So we're just showing you here that if you use 9.5% hydrofluoric acid on the feldspathic veneers, it would be for 90 seconds versus the Emax is for only for 20 seconds. The concentration doesn't really matter. I'm just showing you a different photograph here of a veneer case where you can utilize hydrofluoric acid instead of the 9.5% rather than the 5%, and it's fine. And then the intaglio, and then you're ready to go with your intaglio for the correct amount of time, and then you're ready to go with rinsing that off and then moving on to silane. I'm a fan of 2-bottle silanes. These are the silanes that you have to mix chair side, bottle A and bottle B. And when you mix them together, you then want to apply it to the veneer and then place the veneer in some kind of a warmer for at least 5 minutes. It'll accelerate the silane reaction to completion much faster. This is a reaction that is sped in its reaction rate by having a little external heat also, and it works quite nicely to use this little A-dent composite warmer. It comes with a special little tray that will hold up to, what is this, 10 veneers. So you can put 10 veneers in here and heat them all up and have them all silanated and ready to go. And then I just grab the veneers from here, and or my second assistant does, and applies the porcelain resin to the surface, which helps to let the cement flow better. One thing I wanted to mention about, and this is the silane appearance, which should look basically no different than the etched appearance. Some people think that when you apply silane, you should have a glossy appearance, and that's absolutely wrong. The surface should look dry. And if your surface is glossy after you silanate it, you've over-silanated. And if you've over-silanated, then you really have problems, because you have to kind of go back and get that silane off, which means you probably need to do some kind of re-etching. And it's just a miserable kind of cycle to get yourself into. So one thin layer of silane, that's it. They go into the warmer and they come out 5 minutes later, they're going to be dry like this. So I was kind of mentioning that this porcelain resin that I add, and I'm gonna kind of go back to that for a second. Give me a second. I'm going to go back to that slide here. This slide right here. And we'll toggle into that one right there. You see that porcelain bonding resin that's popping on and off the screen right now? This is added to the inside of the veneer. Now, it's not your adhesive, okay? It's really important for you to understand that this is a HEMA-free unfilled resin. HEMA-free unfilled resin. The reason why I'm placing this on the inside of the veneer is because choice 2 cement is viscous. This will allow the cement to flow better. If you're using a different veneer cement, like a 3M veneer cement is like another example, it's more runny, and you don't really need to have a porcelain bonding resin on the inside of the veneer. But I've found that placing a porcelain bonding resin on the inside of the veneer just makes the choice 2 cement flow so beautifully without capturing any bubbles or voids or anything like that. So it's an added step that's supposed to be partnered with this particular cement. So other cements usually don't have this. Now, what about just taking some adhesive, right? The Scotch Bond, why not just put that on the inside of the veneer to get the same effect? That would be a huge mistake, huge, because all of these adhesives have some kind of HEMA in them. They're very sensitive to the volatile elements that are the molecules that are part of their composition. They need to have the right amount of drying time, and they get kind of tacky. I worry about getting the veneers cemented all the way if I'd use these adhesives on the inside of my veneers. So I don't do it. They also contain HEMA. Even Scotch Bond Universal, that is mainly an MDP primer solution, has HEMA. Almost all of them do. HEMA is really important to add to a lot of these adhesive systems. But on the porcelain bonding resin, it's not an adhesive system per se. It's basically just a facilitator to allow the cement to flow better. And it's because it's HEMA-free, you have no discoloration, which is really important. So I wanted to make that really clear why Dr. Stevenson uses that product and why that product was even developed. Okay. All right. So let's go back to this slide right here where I was. And, here's the case. I'm like, okay, this is going to be easy. And I've got some cotton rolls in there, and I'm doing what probably the lion's share of dentists do, which is they're not going to use rubber dam. And then you notice that I still haven't removed that adhesive on the facial. I got to tell you, I did not see that clinically. I saw it in the photographs after the case. So here I am. I've applied some edge. Boy, I think this is going to be so simple, no problem. And then now you see I've got rubber dam on. You say, whoa, what happened, Dr. S? What happened right after this image was taken was she started bleeding. The acid etch was enough to just stimulate a little bit of crevicular bleeding, and it got worse and worse. And I could not stop it. And I didn't want to go back and pack cords and everything. I said, you know what am I doing? Put the rubber dam on. And this is the way I normally deliver veneers, is I just use rubber dam. I just thought I could get away with it on this appointment. And then we can sandblast the teeth with sandblasting system. This happens to be the one I use, called the Crystal Mark. It's an amazing setup. It's kind of the rig that you want to have if you're going to be doing a lot of biomimetic dentistry. I use it for all kinds of dentistry, not just your biomimetic. It's fantastic for cleaning surfaces. It uses a completely different technology compared to these systems, which these are like the poor man's version. The Crystal Mark, unfortunately, it has to be expensive because it's a lot of technology. It's this big device. It's not very compact either. It's about half the size of a microwave oven. I mean, it's really kind of large. And then you have to have a special cart for it and everything. But it is amazing. It's amazing because it doesn't shoot out a lot of excess aluminum oxide. It just shoots out just the right amount. It's very efficient. This system is completely different. It sucks up it uses a Venturi effect of having the air create a vacuum and pull the aluminum oxide particles into the handpiece and then ejecting them onto the tooth. This is a real mess. But these systems can be purchased for, $400 or $500. And this one right here is about $10,000. Okay, so the veneers the teeth are now isolated. Of course, I'm using a B4 clamp or a W00 clamp. These are those clamps you see all over the Instagram pages, people doing biomimetic dentistry, Rubber Dam Family, Victor Guerrero. They're all over the place. People using these kinds of clamps as though it was a new thing. I hate to break it to all these guys, but B4 clamps I was using in dental school in 1982. It was nothing new. We've been using these retractors since Hunter Brinker invented them in the 1970s. And that's what B stands for. They're named after Dr. Hunter Brinker, a dentist from Florida. His son Richard and I are good friends. He's a dentist as well. And we've known about the Brinker clamps for decades and decades. And so you can try in the veneers now, and you really get a good idea of whether you've got a good fit or not. And the reality is, no, the fit is not adequate in this case. So we're going to try to figure out why. And you look at it carefully and it's like, no way, those margins are not seating. So where's the problem? Is the problem interproximal? Is the problem that the impression was distorted? Is there something in the way of the finish line, not allowing it to get down all the way? Is there something on the inside of the veneer? Is there something on the tooth residual? So you check everything out. And then I use pasta rasa, which is a kind of a red gooey stuff. You can get this from NX Dent, and you can paint this on the inside of the veneer. I don't mind doing that because I have a steamer and I can clean it up. And then you can then place it on the tooth. And as you would expect, you see lots of contact area along the margin, along the cervical area, but then you see that patch over there that was consistent with the resin. This stuff seems to want to stick to resin and really shows you the resin residual. To remove that, it was so simple. It was just a matter of using a scalpel blade, and I just zipped it right off. And then I can rinse this thoroughly. I can, if I need to, I can sandblast again lightly. And then I have to take the veneer, which is really, it's got lots of this material all over the inside of the veneer. I have to now take that and have it properly steamed. So here's a word to the wise. If you want to use pasta rasa, you must have a steamer. You must. You can scrub this for an hour. You can put it in ultrasonic and you will not get this out of the veneer. It's going to be in little crevices and you'll have this little pink dot showing through your final veneer if you don't watch out. Okay. So after steaming it, I still will put it in ethanol and let it sit in the ultrasonic for a significant period of time. This, by the way, this veneer has already been etched and silinated. We are not resilinating. You understand? I mean, people are like, what? Are you kidding me? No, we're not resilinating because I have not done anything to the surface except steam the veneer. And that does not remove the silination. Silination is going to stay. And then we just put it in some ethanol and let it vibrate. If you have some debris in there and maybe you couldn't get a good rubber dam, you got some plaque over the surface, you can always clean this with a little bit of IvoClean, scrub it like this, rinse it, and then put it back into the ultrasonic, get it really clean. I'm really fastidious about making sure everything is super clean, but you don't need to resilinate, which is really cool. So, and realize that I'm not going to make adjustments on the veneer. If my veneers are not fitting, I'm never going to be grinding on the inside of the veneer. That just isn't going to happen. I'm going to adjust the tooth. And if that's not enough, I'm taking a new impression, but we're not going to be adjusting the inside of intaglio of the veneer. So now we're back to, we're happy. We were able to get things to fit and we're going to cement them both at the same time. This is how I always handle centrals. They go in together. And they go in together because any little mismatch, I can adjust them and get them just right. I want to make sure I have good references. I want to look at adjacent teeth. I want to know where I need to end up with these veneers when they're cemented. This is a big deal. In this particular case, it's just these two centrals. That's it. Once they're cemented, they're cleaned up and we're done with the case. So I'm using uni etch, just a full etch, complete etch system. You don't want to use a self-etching system here. Not a good idea. With all that enamel, you want to go for full etching in this particular case. And so this is just a little blurb about from clinician's report. It's a really old one from 2009, but I think it's just important for us to remember that not all veneer cements behave the same in terms of color stability. Even today, some veneer cements are going to be super color stable. Others are going to be less stable. So when veneers are delivered, we want to make sure that we don't have discoloration like you see on this lateral incisor, tooth number 7. You see discoloration, the darkening of the tooth. This is a common problem with some cements. So just make absolutely sure whatever cement you're using that its color stability is unquestioned. And it really has to be terrific. So demand research from your manufacturer on the cements. There are a lot of them out there. Reliax, Veneer, Choice 2, Link. I think these three over here are fantastic. My personal preference is Choice 2, but I've also done cases with the other cements. What you don't want to do is don't use any of these on the right. Don't use your Panavia, you know, the V5 or the Reliax Ultimate or Dual Link. These are not meant for veneers. They're dual cure resins, and dual cure resins have very well documented color shift after cementation. Very well documented. It's okay for posteriors. It doesn't seem to matter because you've got a thick restoration, and perhaps it's just not going to show anyway. But for veneers that are super thin, any of these cements on the right are no good at all. And they're great cements, and we use them, but we don't recommend them for these very thin resin, these veneer cases. While I'm doing a big case, like a 20 veneer case, I just use the same cement for the whole case. So if I'm going back to premolars or even molars, I'm going to use Choice 2 for everything. So I know I've got one cement, one shade, it's all consistent, and I don't want to mess around with different cements for different reasons. So unless you've got a really thick posterior crown, I don't think there's any good reason to veer away from a veneer cement for the whole case. But this graying effect, this downshifting of the veneers has been noted on both lithium disilicate and feldspathic crowns and veneers. And you know, this tertiary amine that's present in a lot of these dual cure self-cured resin cements. There are new dual cures that do not use a tertiary amine, but that doesn't always mean that they're going to have no color shift. So please be careful about this and take a look at the manufacturer's reported literature that shows no color shift, and make sure that it goes out at least 3 years. If you're not looking at least 36 months of color stability, you may find out that the color shift occurs later down the road. So important to keep that in mind. This is that porcelain bonding resin that we talked about. And it's put on the inside by my second assistant these days. And then I apply the cement to the intaglio and then just sort of spread it around. The Choice 2 cement is very thick. And if you're not careful and you push too aggressively, you can break the veneer on cementation. Kind of a scary situation. I don't think it's going to happen very often. And I think if it does happen, what I'd recommend you do, believe it or not, is I'd recommend you just go ahead and cement the veneer with the two pieces and slide them together, because at least you'll have a really nice provisional restoration for the patient. And in my own mouth, 30 years ago, I had veneers delivered, and one of my canines cracked in half at delivery for the same reason, very viscous cement. And the two halves were slid together. They were wiped off, cemented. I've never seen the problem ever since. I've never noticed it. It's never been an issue. But I have basically, people say, how many veneers did you get done? And I go, well, 6.5, you know, because I got this one over here that broke at delivery, but it's actually doing just fine. And so the veneers get delivered. And then after that, we're going to, and this is just a reminder that it's, you know, the material is very viscous. Also, I don't like to tack cure, as you know. I think tack curing is one of the biggest mistakes dentists make. And unfortunately, it was someone thought of it years ago and it never got challenged. But tack curing leads to all kinds of ripped cement from interfaces that will leave irregularities at the interface and ultimately stain propagation at the interface. So we like to completely clean and then completely cure. And so we completely clean, completely cure using floss, using Butler rubber tips, using micro brushes sometimes, but we get it really clean. And then we light cure with air spray so that we're not overheating the tooth. At the end of the cleaning process, before you light cure, of course, you want to put on some kind of glycerin and then light cure the case. And so here we have a mess, right? This is post removal. There's some excess resin that got up underneath the rubber dam. I mean, it just needs to be cleaned up more. And then we need to spend time with the tools that we have available to us to clean off resin at the margin. But one thing you notice in this slide, and these are all of the materials that I use in my practice, in the middle, you have a Wiedelstadt chisel. On the upper left is a number 12 scalpel. Lower left, you have interproximal, IPR type devices made by Contact Easy. I've got serrated blades, serrated saws, different grits, unserrated ones. I've got them all because I don't want to ever be short of that cool thing that is going to remove excess material. And we use them all. But one thing you don't see is a rotary instrument. I don't use rotary instruments like fine diamonds along the margins. I believe that you're asking for trouble. You're going to have a very hard time polishing. In fact, it's practically impossible. So we make sure things fit really well, and then we clean really well, we cure really well, and then we remove residual utilizing blades, interproximal strips, things of this nature. And there she is, finally cleaned up, looking pretty good. She bops out of the practice, never to be seen again, right? I mean, pretty much that's it. I think it was a reasonably good result. I want to thank Sam Alawi and his group from Beverly Hills Dental Lab. They do the work. And I think they're pretty amazing. If you need to do some polishing or adjusting, you need to learn how to adjust the ceramics. So one of the things, and by the way, guys, we're not taking a break. I'm just going to power through and get done. But one of the things that's really important, and we'll get all the questions at the end, okay? But one of the things that's really critical is that you understand the right burrs and the right RPM. And so if we have to use some kind of a diamond to adjust occlusion, and this is not for margins, this is for occlusion, I'm going to utilize a very low speed with a fine diamond, okay? And that means that we turn it even lower sometimes when we're using rubber wheels. So if you have a handpiece that's 1-to-1, you can use, maybe 10,000 RPM. But if you're using a handpiece that's got a red stripe on it, it's going to be a 1-to-5 handpiece. That means 2,000 RPM will kick it up to 10,000. So be careful about, make sure you know your speed, your final speed at the handpiece, not just what is on the unit itself. If you want, you could use some kind of diashine to give a really high polish. I think it's pretty amazing stuff with a goat hair brush. But basically, my go-to is one of these intraorals like this, because I've already cemented the case. I'm in there, I'm adjusting occlusion. I'm typically using T-scan for my deliveries. All my pros deliveries are done with the T-scan digital occlusion method. And I'm finding high spots on the ink, and then I'm verifying with the T-scan, and then I know how much to adjust in each particular area. Okay. If you wanted to, you could get a different system for lithium disilicate, and then you could even get a different system for zirconia. I have all of these, of course, because I like to have all the tools and all the little tricks and all the technology. But I think there are easier, simpler ways where you don't have to have all of these. You could just get the one that you use for feldspathic. You can use it for all of them quite nicely, even zirconia. Just takes a little longer. This is just showing you that you can have the patient bite down on a diamond strip with the diamond particles facing upward. And then you can have them bite down on that, and you can pull the strip out of their mouth carefully, not to grab their lip or something. And this will adjust the high spot perfectly. Isn't that cool? So you have them actually bite down on a wide diamond strip. These are made by Ormco, the company that makes orthodontic brackets and things like that. Have them bite down on this and pull that out of their mouth while they're biting, and you'll be removing the material in exactly the right area to provide them with enough room for their envelope of function. So it's pretty cool. And that's really the last thing I want to talk to you about is this 5-step check. And remember that, when we talk about veneer survival and we look at 93% survival at 10 years, this is considered to be the amazing results of this prosthodontist who published this. Bayer did this in 2012. This is sort of the optimal standard. But I think 65 veneers breaking out of 1,000 in 10 years is too much. I think we can do better. And so, if we have this happen to us, this little chip, that's a nightmare. People look at this and go, oh, that's just a little chip. No, it isn't. That's 2 veneers. For me, if that happens, it's 2 veneers. They're going to come back and they're going to get both centrals replaced because there's no way you're going to patch that with a composite and create a perfect result, nor are you going to have a happy patient. So let's be mindful of the importance of not letting that happen. Let's go for 100% survival at 10 years. Make that your ultimate goal, and I think you'll be happier. This is the kind of disaster that will come into a practice like mine, where the patient is very upset that they had veneers placed and they had chipped already. And just a simple chew test showed me that there were forces being placed on these veneers that did not belong, and the veneers really could have been better adjusted. So let me show you what that means with this 5-step check. And essentially what it is just the first 3 steps are really, really straightforward. We do these in practice all the time. We check MIP, lateral and protrusive movements. And then there are these 2 other tests that I think are going to be kind of novel that I think maybe you're not trying, and you can check it out. I think it's pretty cool. So this is a set of veneers, and they're Emax veneers. They were done while I was at UCLA for a student case. These are not spectacular veneers. They're average, but they fit well. And they were quite affordable for the patient. And so I'm going to show you this particular case because I was able to photograph it and show you all the steps in the 5-step check. So the goal of the first step, and that your veneers are in and your patient's tired, you're tired, and nobody wants to do this because it's just so late in the day and you want to be done, but you have to do it. And I have the patient in an upright position. Okay, I don't do this with the patient laying down. Patients don't chew when they're laying down; they chew when they're upright. So everything is done in the upright position, which makes it very difficult because you're constantly going back and forth between laying down and laying back up, and reclining and then upright, then recline, then upright, back and forth. And I do a lot of stand-up dentistry at the end. My back really enjoys it anyway, because I've been sitting down for the last 2 or 3 hours. It's nice to stand up and check it this way, but the patient is upright when this is done, okay? And so the patient's tap, 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 tap on both sides. We use very thin paper, and then we're looking for areas that are obviously getting in the way of MIP. And what we want for anterior teeth is we want to have very, very light contact on the anterior teeth. In fact, not even hardly registered at all. And it's so easy to determine this using the T-scan because I can see how much force being applied to each anterior tooth, and I know exactly how to level them out. With just paper alone, it's a little bit more guesswork. But a lot of us can't afford a T-scan. Another device that's probably around $10,000. It seems like everything good in dentistry costs $10,000 or more. But anyway, we go ahead and adjust this. And then, you notice when the patient is biting down on the canine, they're going to hold the shim stock, but on the incisor, it's going to slip out. When they squeeze, see it's slipping out, but when they squeeze on the right-hand side, it does hold the shim stock. So the point here is you don't want to have the contact on the anterior teeth or veneers more intense than posterior teeth. So you want to have the anterior teeth barely touching so that the mylar will come out when they bite down. They only can hold the mylar shim stock when they're squeezing. The second check is lateral check. And this is, whether you have canine or group function, the thing is you want to make sure that you have smooth guiding slopes. Don't make them so steep that it's uncomfortable for the patient to disclude, okay? And your incisors are really not touching during this step. So the patient's going to bite down, slide to the right, and then they're going to bite on the other side, and they're going to slide to the right again. And when you look inside the mouth, you really shouldn't be looking at contacts on the anterior teeth. It should be a little slope along the back of the canine. Treat the canine as a posterior tooth when it comes to MIP, and then the canine as the ultimate discluder when it comes to function. So you want to just sort of run the abrasive wheel or cup along this surface just so that that stripe right there becomes a little bit more unbroken. Rather than being kind of little dots, you make it so it looks more like a streak. And it's actually really easy to do. You'd be surprised how fast you can do that. Then we're going to go to protrusive check. And for this check, you just want to have these even bilateral shared contacts. So when the patient bites down on the paper, just have them slide forward. And then you're looking for smooth little scrapes along the anterior teeth as they go forward. And you're going to have a nice even discluding pattern. And there's no way you can avoid the veneers. They're going to hit the veneers as they go through this. This is expected. This is okay. This is what veneers are meant to do. They're meant to be okay with this kind of a thing. And then we're going to do a crossover check. And this check is, by the way, on that back, the key here is you have bilateral even contacts. So if you have like only one tooth that's discluding, and you're like, wait a second, what's going on here? That's not good. That marginal ridge is a little bit over contoured. Then you adjust it so that you get more uniformity bilaterally at the very least, two centrals, two laterals, two canines, however they happen, the timing of that is probably not as important as it is that they're, well, it is because they have to be at the same time. So you want to have a lateral and a central on one side discluding at first, and then it starts to disclude on the other side. You want to have it so that it's more matching lateral, central, canine, like that. Crossover check is really one of the coolest things. Frank Spear taught me this check many years ago. But basically what you're trying to do here is get broad incisal edge contacts when the patient goes edge to edge. And then you want to have all of these edge to edge positions very gliding. You don't want to have any catches. In other words, you don't want to have one tooth when the patient's going forward edge to edge, you don't want to have that one tooth banging into another tooth. And even though you did this in the provisionals, and you can see those lower incisors have already been leveled out very nicely during the provisionals, sometimes there's a little bit of discrepancy between the provisionals and the final restorations. And so you may need to do a little bit more adjustment. So that would need to be adjusted. I like using a wheel for this. Now you don't want to round off the edge. Okay, that's the key, is that rounding off the edge makes the tooth look funny. So what you want to do is you want to just recontour the edge. So you reduce it more from the top and you reduce it more from the front. Does that make sense? If you round off the corner, that's the fast way to get it done, but you end up making all the lower teeth look weird. They don't look like incisors, not to mention the fact they don't have the chewing efficiency. So if you're going to be adjusting lower incisors to match with the veneers, do it in a way that maintains the morphology of those incisors. And so now the patient can go forward, side to side, and they can glide around in all different directions with no discomfort, with no catching. And, those lower incisors should pretty much not have very well established embrasures. They should be pretty much, straight across. And then the final check, and this is really a check that you did before you even started the case, and then you're going to do it when you deliver the case, and you did it during the provisionals. So you did it at the start, before anything, you did it at the provisionals, and you do it again at the delivery, and that's the chew test. And this is just so easy. you want to use really thick paper. So I thank John Coyce for teaching me this trick probably also a couple decades ago. And what we do is we have the patient chew on gum, or they can chew on a ball of wax. And while they're chewing, we don't really even look at them. We just let them chew and let they're chewing along, and don't even stare at them, because it's funny when you stare at a patient while they're chewing, they'll chew differently. Just let the patient chew normally, and they'll chew, and have them stop midway through one of their chewing cycles, insert the 200 micron paper, and then just kind of hold it casually, not even looking at them, but tell them to keep chewing for about 10 or 15 more chews. And then what happens is you'll start to see, sometimes you'll see marks, and these marks are glancing blows during the chewing pattern. So while this patient's chewing, these anterior teeth are sometimes rubbing against each other. That's not good. You'll see dark marks down along the cingulum areas because that's where you have MIP, and those you're not going to touch because you've already adjusted that. But what I'd recommend you do now is adjust any of these marks that are getting in the way while the patient is chewing. These are the kinds of things that lead to fractures. And it's uncanny how obvious it is in cases that could have been prevented by just performing a chew test, these obvious situations of fractures. Excuse me. Okay, so if you can perform this before you even start the case, and again, after the case has been delivered, during the provisionals, of course, and then after you deliver the case, you'll have a really good idea and pretty confident that your patient's going to be not having any fractures. It's really important to follow really 4 things, in my opinion, and understand that the envelope of function cannot be constricted. It cannot be, this chew test has to be done, and you need to make sure your patients have enough room for the veneers. I do witness a significant amount of veneer cases that are done without understanding this. And the problem is you lengthen the teeth, they start getting in the way, and that's a recipe for potential fracture in the future. If the patient is a bruxer, obviously an orthotic is required for nighttime use. Patients need to be told only to use their teeth for food, which sounds crazy, but a lot of patients use their teeth for other things that are not food. And then you need to be mindful of the fact that, remember, veneers can fail because of caries and because of periodontal disease. So we always want to make sure that we're taking really good care of the patients from a standpoint of caries management and periodontal management. When it comes to these 3 aspects, habits, forces, and disease, these are shared responsibilities. Habits are all the patients, but when it comes to forces and disease, we need to have a partnership with our patients so that we're constantly checking these things. I will perform chew tests on my patients that have veneers periodically to make sure things haven't shifted and we don't end up having forces put on the veneers that could cause problems. So we adjust them at delivery, and then we continue to adjust them throughout the life of the veneers to make sure that we're constantly checking. It's just like your car. You know, after you wear your tires on your car, your alignment goes off, you go over a speed bump too fast, all these kinds of things are happening to our vehicles, and we constantly have to make maintenance adjustments on our cars. And yet dentists, we sometimes think that once the veneer is done, it's done for life. And I think that that's probably a little bit of a naive perspective, because we're using our teeth every single day, and to think that things are going to be stable without needing to have maintenance is kind of it's hard for me to imagine that that would ever be possible. This is one last case. This is not a very successful veneer case, do you think? This was performed on a young guy. It was done on the East Coast somewhere. Surprising that kind of dentistry was done, but he had some recession and a lot of staining around the margins, not the kind of case that we like to see from our fellow dentists, but it needed to be redone. So obviously, I think we all agree that we need to get going on fixing this. The case is probably done with composite. I don't really know if it was direct or indirect. You really don't always know. You think you know, but it's not always true. But a case like this, you don't know what's underneath. This is my provisional that I made for the patient, and I made the provisional on an impression of the preparations, and I made a quick provisional in the mouth, but I made this special provisional for him to wear to tell me if he really liked it. I was doing that a little bit more often in the past because I wanted to have my patients guarantee me, that they love the veneers. So this was made with composite and composite staining and translucencies so that the patient could, and they spot bonded this and gave it to the patient to wear. And I said, what do you think? Oh, I love it. I love it. Okay, great. And now we can come back and do the veneer case. The veneer preps were made, and these are dyes called Geller dyes, G-E-L-L-E-R, Geller dye, because they're removable. It's pretty sweet, right? So your technician can be working off of a removable dye like this and insert them back into the mouth and then make the veneers. The veneers were done by a technician named Chang. He's no longer in dentistry. He retired from being a laboratory technician, but I think he did a nice job. A lot of characterization. These were feldspathic veneers, a lot going on in a very, very thin space. Pretty remarkable, actually, that that much was done. The cases here, they were kind of like 3/4 crown type of preparations. The patient must have had some diastema in the past. Most of what I did when I prepped this case was just clean up all of the resin that was slapped on there. And then the result here for the guy. And it was a good little case, nice little result. And it's kind of fun to turn people around and provide them with services like this that can actually last. And that's the whole objective here, is that, everyone's talking these days about beauty and veneers and, your typical Instagram before and after with the amazing photography, obviously done with additional lighting sources and things like this. But it really doesn't tell you anything about the function of the veneers. They may look good in a highly adjusted, light crafted photograph, but what do they look like in 10 years? That's always been my concern. All of my veneer patients have stuck with me because they know that I'm going to take care of it if there's a problem. And the number of problems that we have after doing these adjustments and following all these steps is quite low. Most of the time when things fail nowadays, it's because the patient had gone through a period of neglect and maybe had a carious lesion start on a tooth, or the other issue could be occasionally they will forget to wear the night guard and they'll get a chip and they'll admit to it, or it's a traumatic injury because they try to open up something with their teeth and they chipped an incisal edge, something like that. Those are the more common things that we see. I rarely would see a patient that would say, my veneers, I did everything perfect. I followed all of your guidelines, doctor, and they still chipped on me. What's wrong with your veneers? Those days just aren't part of my life anymore. And I don't think they have to be part of your life either. If you're going to do big veneer cases, that's great. Go ahead and do them, but do them well. And I think that's the take-home message is if you're going to engage in veneer dentistry, you need to do it at the highest level. We do have courses. If you're interested, we have incredible hands-on courses. We have in San Dimas, we have a course on June 4th that is sponsored by the Southern California Academy of General Dentistry. That course sold out in 3 days. We have another course in August at UOP that is a long veneer course. It's a 3-day course. You can check that out. From last time I checked in with them yesterday, the course is almost sold out again. Then we have another course back at our center in San Dimas, which will be a 2-day course. So you have, there's a lot of these options available. And I think it's pretty cool because you get to actually do veneers in the course on artificial teeth, but you get to cement veneers in the course, which is really kind of important. This is my email. Please reach out to me at any time. I will respond to any questions that you have after the course. So if you're watching this as a recording, I would welcome you to send me any questions you might have or comments. I'm more than happy to get back to you. I really enjoy communicating with dentists from all over the world. I mean, it's kind of what I do. I love dentistry, as you guys all know. I'm very passionate. I'm actually teaching I'm in day 4 of a 7-day course right now. I left my course early to give this webinar, and I'm probably going to go back to my teaching center at 8 o'clock because we don't finish till 9 p.m. Anyway, I love it. It's a lot of fun, and I certainly appreciate everybody's patience and your resiliency in making it through 5 2-hour sessions. So with that, I am going to stop talking and open it up for questions. And I'm going to turn it over to Devin, who can moderate and maybe ask some of the questions, and I'll do my best to answer.
Yeah, thanks, Dr. Stevenson. So we had a couple questions come in. The first one at 6:42 Pacific from Milo. Can I ask lab to pre-etch the veneers?
Yeah, labs can pre-etch the veneers. I think it's a really good idea. And it can save you a lot of hassle, but here's the thing. You got to teach them how to etch the veneers. Make sure they know to etch around the edges. And so you train them and they're okay for the first case. And then the second case, you're not sure if they did it or not. And then by the third case, you have to go back and train them again. So labs have a lot of turnover. And at first they'll do a really good job, and then they'll delegate things, and they can try to keep it up, but sometimes it happens, sometimes it doesn't. So it's been my experience that your labs can do this incredibly well. And but I would highly recommend that you stay on top of them and reinforce this over and over again, and realize that labs have turnover, right? I mean, there's not the same lab technician that's going to be there every single time you send a case in.
Yeah, I worked for Vita before this, and I would see that often. Dr. Stevenson, do you know, as a clinician, do you work with more than one lab? Or I know you mentioned Beverly Hills Dental Lab. They're legendary, right? But is there more than one lab you'll share?
Oh yeah, for sure. And the thing about Beverly Hills Dental Lab is that you can get their regular bench veneer, the one that's done by whatever team is doing the veneers, and they're pretty awesome. I'm so happy with the fit, consistency, and you can also, if you wanted to, upgrade all the way to the Michel Magnier version, and get super customization on a patient that maybe is a high level VIP, something that won't even allow you to do photographs, and then or sometimes you get patients that are extremely wealthy that can afford the additional lab fee that comes with that. You have to understand that I charge my veneer fee plus the lab fee if they go beyond the regular veneer that is offered by Beverly Hills. Another lab that is really good, there's Tim Dental here in California. I think they're incredible, TIM Dental. And then of course there's Ultimate Styles, which is Naoki Hayashi. He's in Irvine, California. His quality of his veneers are phenomenal as well. But you have to get used to the idea of paying up to $1,100 for the lab work per veneer for that kind of level. Michel Magnier at Beverly Hills is going to be more than that. And for some patients, that's a no-brainer. They're more than happy to pay for that. But what I've done is my fee will be set so that the lab fee is included if they do the basic Beverly Hills Dental Lab technician case, which is actually quite good. So I think people pretty much today that I've spoken to a lot of dentists around the country, and it seems to be the going rate for a high quality veneer is somewhere in that $350 to $500 range for a good solid veneer that is going to look really pretty. But then you can double or even triple that price if you want to go for the elite service. So it's the lab industry is they're in trouble. They're in trouble because a lot of the masters are not being trained anymore. First of all, there's no lab schools in the country anymore. It's not like you can graduate from high school and say, I want to be a lab technician and go to lab school. It doesn't exist. It's all through apprenticeships. And with digital taking over, so much of this stuff is delegated to computers and dedicated to designers that aren't even technicians. They're relying on the tooth libraries to develop contours and things like that, and they're milling things. So I'm really worried. So much so that a friend of mine and I are thinking about starting a laboratory technician training program, because I think it's a huge issue. If you find a great lab that does veneers, stick with them, because a relationship can foster there that you can take advantage of their knowledge for years to come. But keep in mind, turnover happens, and the guy in charge has got to be on your side. So sometimes if a case is kind of in between a high level boutique kind of case that'll take many weeks to do by a master technician, I'll have the lab owner personally supervise the case and say, look, this is really a special case. You've got to be on top of it. And I've never been let down when I have that communication going with the lab.
Okay. A couple more questions here from our, said you put them in the warmer for which reason and to which temperature?
I just turn on high, and I do it for at least 5 minutes to 10 minutes or longer, because I have them in there the whole time while I'm doing the case. The warmer is going to drive the silane reaction to completion because it's a 2-bottle silane system. Also, having the veneers warm, and it warms them up to like body temperature, a little hotter than that maybe. The composite, when you apply it to the veneer, flows beautifully. And it's kind of a warm composite technique, isn't it? And we all know that is the best way to get the highest conversion rate and strength out of our composites, to use them in a warm state. So the composite's not warm per se. It's at room temperature, but once I put the material into the veneer, it heats up to the veneer warmed temperature. Remember that the reason for this primarily is to drive the silane reaction to completion and get better silanation of the veneer. But also, it's great when they're warm because the cement just flows beautifully. I've been using the warming technique for probably about 10 years. I am so glad I do it. It's fantastic in terms of just facilitating the veneer cementation onto the tooth, getting the veneer to spread out evenly. It just seems to be a pretty nice technique to do.
Yeah, the flowability probably is great. Another question here from Ala. I get gray stains around my temporary margins. How do I avoid it?
Right. Sometimes the staining around margins can be from the medicaments you're using during impression taking. Definitely don't want to use ferric sulfate or ferric chloride when you take veneer impressions. Just only use clear aluminum chloride, 25%. That seems to help. I don't know what else might be the issue, but I've seen this happen, heard about it happening, and I think it may be coming from that. But if you're not using ferric chloride or ferric sulfate, and you're only using aluminum chloride for your astringent material, I don't honestly understand why that would be happening.
Okay. Next question from Masima. What's the reason for putting glycerin before curing when cementing the veneer?
Yeah, the glycerin is just going to cover over the composite that it's exposed to the air, right? And it's going to then prevent air from inhibiting the polymerization reaction. It's kind of it's a mouthful. The glycerin will remove any air from the area because you're covering it with glycerin. So basically you're suffocating the margin with glycerin, right? And then when you light cure through that, it will cure to completion. rather than having a tacky layer on the surface that could be washed away. And I think
Mm.
it's particularly important when you're doing the technique that I subscribe to, which is bullnose etching and clean and cure. I never do tack cure because I want that interface to be just pristine and really hard. And I want it to behave like a class 5 composite. And by putting the glycerin on the surface and light curing through it, we can get a complete cure rather than having an air inhibited layer, which is tacky, gooey, and uncured.
Okay. Any other questions, folks? Really appreciate them.
Woohoo!
Speak now or forever wait to the next webinar.
Or no, you can reach out to me anytime, or better yet, you can see me in person.
Yeah.
We have students from Asia, from all over the Middle East, come to our courses. California is a nice destination. Come out here, hang out, do some fun things. Go to my course, write the whole trip off, bring the family. And it's kind of cool. So I hopefully we'll get to meet some of you and in person. That'd be cool.
When's the next course?
Well, I'm in the middle of one now. Then I got another one on Sunday, June 4th, which is a veneer course, but it's already sold out. And then I have another course on June 5th, 6th, and 7th right after that. Completely different course. That course is totally sold out. So things are going well. I feel very blessed and very fortunate to be in my element, to be enjoying the teaching, enjoying patients, interacting with quality people like my friends at Univet. And just all in our common desire for excellence in our profession, the most amazing profession on the planet. So if I get to hang out with you, it would be great. And I would welcome the opportunity to have you in one of our courses for sure.
Well
Thanks so
said.
much, Devin, for everything, and Univet
My
for
pleasure.
innovation and for having the coolest loops in the world. That's not even close.
Thanks
You
so
guys
much.
own it. You own it. And just wishing everyone a really great evening or morning, in the case may be in Dubai. I think you guys are in the actually in the early morning over there. So wishing you all the very best. And I think that's about it. So keep in touch.
Thank you, everybody.
Bye, everyone. Take care.